Good morning, ladies and gentlemen, and welcome to the webinar, Sterilization in the OR, Just the Facts, Transitioning from STERIS System 1. Please note that this presentation is being recorded. If you have a question during the presentation, you may submit your question at any time by typing your email address and question into the boxes below the slides. We will handle as many questions as possible within the time allotted. If we don't have time to answer your question, we will follow up with you after the webinar has completed. I would now like to turn the presentation over to Karen Borg, Vice President, Global Marketing for ASP. Ms. Borg, you may begin.
Thank you for joining us for Sterilization in the OR, Just the Facts, Transitioning from STERIS System 1, the third in a series of webinars sponsored by Advanced Sterilization Products. We know that this is a confusing time for many, and we hope this webinar series helps you sort through all the information and make informed choices. In our first two webinars, we discussed the unprecedented situation that many healthcare facilities now face after the safety alert issued by the FDA on December 3, 2009, regarding the STERIS System 1. If you weren't able to attend or would like to view them again, you can do so at www.aspjj.com/alternatives. As facilities try to determine the best alternative to fit their sterilization needs, some confusion remains about which machines provide sterilization and how quickly the transition needs to happen. The recent release of the STERIS System 1E has created further confusion for healthcare professionals, as the FDA has stated that the end product is not assured to be sterile. In our previous webinar, Chris Nader of medical device company Esculap highlighted that the FDA-mandated transition from STERIS System 1 to a legally marketed alternative has brought to light the need for additional education regarding sterilization and various sterilization methods to enhance patient care. In today's webinar, we hope to bring you just that. Today's presentations will review some basics about sterilization. We know that you live and breathe this day in and day out, but we think it's important to get back to why we do this and how the situation has evolved. We hope this webinar will help you understand the value of terminal sterilization and provide you with the information and resources that you need. Today, Patty Fritz, a registered nurse here at ASP, and Charles Roberts, also at ASP, who is a microbiologist and the Director of Research, will take you through the facts on sterilization to help you transition from the STERIS System 1. Patty Fritz will cover the history of sterilization, and Charles will cover the science. After the presentation, we will open up the webinar to questions.
Thank you, Karen. Good morning and good afternoon, everyone. As we begin our discussion of microbiology, I think it's essential to start by remembering why it's important and the history of this area. We all know that sterilization and disinfection are important to prevent infection and death, but I think that the lines between proper sterilization, almost sterilized, and high-level disinfection, or HLD, are blurred by some people. I will touch quickly on some basic definitions to make sure everyone is starting in the same place, and then review some of the recent history around operating room sterilization. I sometimes hear the terms disinfection and sterilization used interchangeably, which is very concerning to me. This is incorrect and very misleading. In basic terms, sterilization is the destruction of all microorganisms, including spores. HLD can be anything less than that. In the operating room, these differences are critical and can mean the difference between life and death. As you all know, we still use the Spalding system of classification today. Critical instruments enter sterile tissue or body cavities, break mucosal barrier, and/or enter the vascular system. Examples include choledocoscopes, biopsy forceps, and angioscopes. Semi-critical instrumentation comes into contact with mucous membranes or non-intact skin and is commonly cleaned with high-level disinfection. Examples include endoscopes, laryngoscope blades, and respiratory equipment. Non-critical instrumentation comes into contact with intact skin, but not with mucous membrane, and low-level disinfection is used. Examples include bedpans, stethoscopes, and blood pressure cuffs. As promised, let's take a look at the past so we aren't doomed to repeat it. The truth is, the advances in sterilization and infection control have been outstanding and allow us to do the amazing things in the operating room that save and improve lives every day. The STERIS System 1 provided a much-needed service and was best practice at that time. Just-in-time processing was the best we had then. The nature of surgery was changing with more minimally invasive surgeries, which required faster turnarounds with busier OR teams. STERIS answered that need well. Time marches on, and advances in science and technology have allowed ASP to pioneer low-temperature terminal sterilization. Terminal sterilization quickly set a high standard because it allows for sterilization and processing in advance, so there is less prep time before surgery. We are lucky that there are choices, including just-in-time processing and terminal sterilization, and are fortunate that now we can protect patients with superior sterilization options. Today, we have multiple choices for processing surgical equipment. Let's go through how each works and the best choices for what you need. There are a number of pros and cons to each. For just-in-time processing, devices are processed directly with a sterilant, and after processing, devices must be used immediately or run the risk of recontamination. For terminal sterilization, a key advantage is that devices are wrapped in a sterile container or sterile packaging and then processed, which means after processing, devices can be used immediately or stored, maintaining sterility. This means that it is terminally sterilized and can be done in advance, reducing immediate pre-op prep. Since we know our history, we are not doomed to repeat it, but rather we are made wise.